Overdose deaths increase year after year, and youth mental health problems continue to increase. All healthcare workforce conversations really must be inclusive of mental health and substance use service providers, including the allied health professionals, such as peer specialists. Additionally, all healthcare and emergency crisis conversations must discuss access to effective peer support services alongside other forms of care. Research shows that time and time again, the mind-body connection cannot be overstated. It is past time we design primary care and a public health strategy that considers primary prevention of mental health conditions, getting to the root of issues in childhood, as 50% of mental health conditions show signs and symptoms by age 14. For young people, this means allowing them to build peer support programs in K-12 schools and higher ed campuses as part of universal mental health education and in connection with other systems that they engage in. For adults, this means addressing supervision and pay issues of the workforce in Medicaid, clearing up confusion about newly reimbursable peer services in Medicare as part of crisis psychotherapy. And we should build on top of that work to allow all community mental health providers to bill for peer support. It means also to train the healthcare workforce about how to effectively incorporate peer services into workflow and scale up peer support in maternal units, in Medicare, as part of integrated care. And we should use the best practices of the Veterans Health Administration, which has had peer programs for over a decade. In the fiscal year 2023 Consolidated Appropriations Act, Congress took the first step to recognize peer specialists in Medicare as auxiliary personnel. And while that was a helpful first step to realize the benefits of peer support services for everyone who needs them, they should be fully covered in Medicare as they are in Medicaid and at the VA. So what is peer support? At the heart of peer support is lived experience, that learned lessons and strategies from one's life experience may be used to help others navigate similar situations. While we all have unique experiences, many of the challenges that arise and systems we're required to navigate are in fact similar across states. Peer specialists help people engage in care, help people set and reach their own goals in both their mental and physical care, educate and build self-advocacy skills, and lead to reduced hospitalizations, which can be very disruptive. Peer support recognizes that the human experience thrives off healthy attachment, connection, belonging, and relationship, for which there is no substitute. And considering that behavioral settings have a history of abuse and are still traumatic for some people, models of peer support are life-saving for both individuals who receive youth or adult peer support and families who receive family peer support. I'm really excited for you all to learn more about peer services today, as they are offered as part of respite and warm lines, and we need help increasing resources to scale these efficient community-led programs. The president recognized peer specialists as a critical part of the behavioral health workforce by prioritizing the certification for peer specialists in his current Unity agenda, and his administration has continued to actively address the current crises. We appreciate Congress is also having conversations about behavioral health, especially as it relates to the expired 2018 Support Act. I'm pleased now to turn it over to Congressman Adrian Smith of Nebraska, who was the lead sponsor of the Peers in Medicare Act in the 117th Congress, along with sponsor Congresswoman Judy Chu, and has contributed to work with us, and has continued to work with us to get legislation introduced in the 118th Congress that builds on top of last year's work. He is an esteemed member of the House Ways and Means Committee and a champion for rural health care, including access to mental health and substance use treatment. And we are so grateful for all of his support and hard work to expand peer services, especially in rural communities where people want to talk to those they can relate to, who understand them, and who have similar values. Please welcome Congressman Smith.
Well, thank you so much. It's great to be here. Good afternoon. I appreciate the opportunity and the invitation. The work that is being done for and with peer support, I think, is very, very important. I represent a district that's 80 counties of Nebraska's 93 counties. We have 2 time zones, and saying rural is not a full description of the district. There are remote parts of the district as well. I sometimes refer to the distance as how far it is to the nearest Walmart, or maybe McDonald's. But the distances are vast, and obviously that provides a challenge for providers in all of healthcare, and especially mental health care. And it's been my joy to learn more about peer support and peer specialists and how effective that can be. And I think that's especially important to realize that it's effective in its approach, and it's also cost effective. And I think that's a win-win when it comes to important parts of healthcare, and especially mental health care. So thank you for your work in the field and bringing people together here today to hopefully focus on the future and bringing people together to focus on solutions. It's really easy to say what the problems are, but it's a little more challenging to focus on the solutions. And I want to devote what I can to focusing on solutions as we face the future together. So thank you again. I apologize I can't stick around with other meetings and so forth, but I appreciate the opportunity of being here. Thank you.
Thank you so much. I'd like to thank you so much, Congressman and Joel. I'd like to welcome Emily Silverberg from Congressman Paul Tonko's office, who's also a legislative champion and represents parts of New York.
Thank you, everyone. I'm so excited to see everybody here. For those who don't know me, I'm Emily Silverberg. I serve as the legislative director for Congressman Paul Tonko. Really lucky, in addition to getting to do the healthcare portfolio for him, I get to help him with his work on the Addiction Treatment and Recovery Caucus. So doing a lot of work. I recognize a lot of faces in here. And if we haven't connected, please reach out to me and connect and see what we could do together on this. The congressman, unfortunately, his Amtrak got delayed due to some issues in New York today, and so he is running behind and sends his regards. He asked me to just share a few words with you all here today. So he said, welcome, and sorry I cannot be there with you today. However, I wish everyone a successful briefing and a productive discussion. On behalf of the Addiction Treatment and Recovery Caucus, or the ATR Caucus for short, welcome to today's briefing. The ATR Caucus has a long history of strong bipartisan support. I serve in the ATR Caucus leadership as co-chair along with Congressman Dave Joyce and Vice Chairs Congresswoman Dean and Congresswoman Chavez de Reamer. During today's briefing put on by Mental Health America, the National Association of Peer Supporters, the Mental Health Liaison Group, and the Alliance for Rights and Recovery, we'll hear more about the role of the peer workforce. I strongly believe we must do more to ensure that peer support is part of the equation, especially in addressing the overdose crisis. Today we will get to learn more about potential legislative solutions. I welcome our speakers and urge all of us to listen, discuss together, and plan how we could act together so that we can in turn better address this crisis. And a special welcome to our panelists from the Capital Region, Tiara, Springer, Love, and all those here today from New York, and especially those from the Capital Region. So thank you to all of our panelists. Thank you to Caren for organizing this. Really excited.
Thank you so much, Emily. So at this time, I'd like to allow the panelists 1 minute to introduce themselves, and then we will give them 4 minutes for opening remarks. So we're doing this in a very organized fashion, and I'll allow Congressman Tonko's constituent to start off.
Hello. Can you guys hear me? All right, good afternoon, everyone. How's everybody doing today? Okay, I love it. So I'm Tiara Springer Love. I'm originally from Queens, actually. Albany likes to claim me, but I'm originally from Queens. I'm from Albany. And what brings me to this work? A failed suicide attempt. That's what brought me to this work, right? Being in school, not having the proper support, being a young adult, not having the proper support, being the first out of my biological siblings to go to college and still not have the proper support, currently sitting in front of you as a youth peer advocate and a licensed social worker, still fighting to get the proper support. it's a challenge doing this work. And what keeps me in this work, seeing the hope that we give young people, seeing the hope that we give parents. What keeps me in this work, having people like Caren and Paige Pierce, who's the CEO of Families Together, and Harvey, who are fighting to make sure that we all have a future, right? So I've navigated the child welfare system, I've navigated the foster care system, and I feel as though, and I know that peer support is not only effective, but peer support is something that's being desired and asked for by young people. At Families Together, we believe in the philosophy, nothing about us without us. So how are we gonna make decisions on behalf of young people without having them at the table? So I think my minute is up. So I'm gonna pass it on over and I'll dive a little deeper when we start talking about the different questions that we have. Thank you all.
Wonderful. Hi, everyone. My name is Lauren Foster, pronouns she, her. I'm with BlueCross, BlueShield of Minnesota, and it's an honor to be in front of you today. Big welcome from Minnesota. In my current role as behavioral health program manager at the company, I specialize in bringing benefits, coverage, community programs, and clinical outreach for our case management teams for our members in the state of Minnesota and nationally. My experience working with peers, I was a behavioral health home director, which integrates peers into clinical teams for a few years prior to coming to Blue. And the first assignment that I had was to get a new benefit for peer coverage across the line, which we will dive into more later. Thank you.
Hello, everyone. I'm Vesper Moore. I use they, them pronouns. I am the Chief Operating Officer at the Kiva Centers, a Massachusetts-based organization that has 3 peer-run respites, trained certified peer specialists, and does a lot of great work with individuals with life experience. What brings me to this work is someone who has direct life experience navigating the mental health system and looking for resources in the community. And I eventually found peer support, which really brought me to the workforce and really brought me to this executive level at a peer-run organization. I think of peer-run organizations as brilliant opportunities for our communities. I think they are absolutely critical resources that fill a lot of the gaps that we see in behavioral health today. I think they are affordable and effective, and I look forward to speaking more on that.
Thank you, Vesper.
Good afternoon. My name is Dana Foglesong. My pronouns are she and her. I'm a native Floridian, born in Naples, live in Fort Myers now. I've been a certified peer specialist for 14 years and have had leadership roles in peer-run organizations, in state government, and in managed care. And today I'm representing the National Association of Peer Supporters, where I serve as the immediate past president. NEPS, which we go by, is the Workforce Association for Peer Support. So we have members across the country who are doing the work every day of providing support to individuals and giving them the hope that they need. And I'm very excited to share more about that with you.
Thank you all so much. I wanted to give each panelist a few minutes to talk a little bit more about their work, the kind of challenges and solutions they see, and maybe one takeaway from all of that. Tiara, would you kick us off?
Sure. So I work at Families Together in New York State, and we are the credentialing body for the youth peer services and family peer advocacy services, which is a Medicaid billable service. And this year, Governor Kathy Hochul, she did a youth mental health listening tour around the state. And she also did the first ever youth mental health youth summit, which I had the privilege and opportunity to lead. So I was able to go around the state, speak with over 200 young people. And some of the most common things that young people spoke about, including youth from rural communities, suburban communities, and from the city, they all said the same thing when it came to the desire to have youth peers at school. One thing is that we say all the time, representation matters, but no one ever says why, right? And representation matters because it gives young people hope. because they get a chance to see themselves in others. Outside of seeing themselves in others, it's also suicide prevention. I've had young people say to me, Miss Tiara, I've never seen an older person with bipolar disorder. Like, is there a future for me? Like, will I be able to maintain a job? Because the doctor told me I won't be able to, and I'll be on these meds my entire life. And when I can bring an adult there who has been successful in receiving peer support and delivering the service and say, yes, because this person has done it, and they can be a great support or mentor to you, right? So youth peer support is not just about me sharing my story, because it's like you have friends for that. But it's very different than clinical services, because you're able to provide a sense of support when it comes from the heart, not from what you learned in a book, right? It's very different. And I'll ask you all to think personally, if you've ever lost a parent or a loved one, would you rather get support from someone who's also lost a parent or a loved one, or just someone who's never had any life experience? And for the most part, we all would rather someone who can relate to us. So youth ask for peers. Youth also ask for just practical skills on how to cope. COVID did a number on the young people in the community. So youth who already had challenges, their challenges were exacerbated, and youth who never had challenges were experiencing them. So that was the other thing. Youth were asking for coping skills and just resiliency building. And then the last thing youth asked for across New York State was support for their struggling parents. That's another aspect that's also left out, and they believe that children don't think about their parents. I know with the youth that I spoke to, little do you know, they're thinking about you, right, for the parents in the room, and they want their parents to be well, right? So what supports are we putting in schools to provide support to parents? And that's where family peer advocates also come into play, to provide parents with support. Do you want me to go into the funding stuff or not yet?
You can wait.
Okay. So those were the main things. And as an advocate and as a young person who has navigated systems, I find it to be my job to bring their voices to you, right? So this is not what I want. This is what young people have been asking for, and this is the work that we do at our organization. So thank you.
Wonderful. Great job. Thank you. All right. BlueCross BlueShield of Minnesota's mission is to pave the way for everyone to achieve their healthiest life. We've taken a leadership role as the first local payer in Minnesota to provide $0 coverage of in-network peer providers as of 1/1/2024. We're ensuring affordable access to this necessary, culturally inclusive, trauma-informed service for all of our members with a behavioral health diagnosis. Right now in the state of Minnesota, as in much of the nation, when we look at Medicaid services, it's a very specific criteria that members are able to access. In Minnesota, you need to have high impairment and high acuity. Typically, it's severe and persistent mental illness, leaving a vast hole of members who would benefit from such a non-clinical role. We have seen peers positively contribute to treatment outcomes over the last decade as we've approved Medicaid coverage. So these look like reduced rates of symptom reoccurrence for our Medicaid membership, as well as feeling more connected, more hopeful, staying out of emergency rooms, hospital stays, and have found this non-clinical service to be vital. We're excited to be here and to continue to partner in this work. We would love to see other payers at the table. We find that to be really critical to build this infrastructure, not only in Minnesota, but knowing that we have national clients, we're invested in everything that happens across this nation. For this to happen, we need legislation that clears out the pathway for training for peers. Right now in Minnesota, if you would like to become a mental health peer specialist, you'll be on a wait list to be able to go through a training class. If you specialize in recovery and substance use, you would be able to get in. If you want to be a family peer specialist, there currently is not a training program for you. Those are the 3 types of peers we've approved. And when we look at, as you so wonderfully said, about youth and families, while we have coverage currently for family peers, we have a critical shortage in that area. And family peers specialize in having gone through the experience themselves. So this is a parent, a caregiver who has had a child with a mental health or substance use diagnosis. They're 1 year past having that. The family has successfully found treatment or support in the community and more stable. Something that I think we all saw through COVID is that families need more support. So we're asking that in this time that there would be legislation that could help just open up those inroads for training and allow more individuals to become peers. Thank you.
Thank you.
In the United States, there was a promise when we first looked at deinstitutionalization, emerging a promise of having robust resources in the community, and we see robust community behavioral health expansion throughout the United States today. I think considering Kiva centers and our work in Massachusetts, we're looking to have peer support be a vehicle, an entry point to continue that promise, where we are meeting people in the community where they are and ensuring that they are getting what they need in those moments. I think some of the challenges that we face within this is people understanding the roles of peer supporters. I think there are so many different types of peer supporters, from the firsthand perspective of someone who's navigated a system and has been the person who is in the driver's seat, if you will, navigating those experiences. And then we have family members who support someone through that process. Then you have the experience of being a young adult, and being, someone who is, both developing mentally and navigating systems and learning who you are in this world at such a quick pace. So I think the role for each of these different peer support roles, each of them are valuable. And I think sometimes people conflate peer support roles. We see that a lot. So for us, it's been public education about why each of these roles are valuable and how they contribute to communities. A family member, a parent is going to want to talk to a parent. A young adult is going to want to talk to a young adult. A person who has survived and navigated systems and is exhausted is going to want to talk to someone who's felt that exhaustion without judgment, discrimination, or anything else otherwise. So it's absolutely critical when we consider that in the role of peer supporters. At Kiva Centers, we certify peer specialists for the state of Massachusetts in the context of mental health. And that co-collaboration with other certifying entities has been critical. We developed a Massachusetts Peer Workforce Coalition for this very reason, talk about the value of the differences of these professions and how we can come together and continue to work together. I think another piece is when we talk about peer-run respites, which we will be talking about more, considering what the billing process can look like that really ensures that peer supporters are autonomous in their role, operating within the values and the ideas of these professions. I think that's so critical because when we talk about these values and these ideas, they are founded in the idea that we are able to share our lived experience openly. We are supervised by someone who understands to some degree what that lived experience is like, how it is to navigate an integrated team that might not understand those experiences as well, is just so critical. Thank you.
Thank you, Vesper.
So peer support is very personal for me. 20 years ago, about 150 miles from where we're sitting now, I was being discharged from a state mental health institution for the second time after being involuntarily committed. And at this particular discharge, the psychiatrist said to me that I needed to get on Social Security disability because I was never going to get better. Obviously, he was wrong, so I'm sitting before you today. But he was almost right. because prior to that, I had Medicaid as my insurance. And then after that, I actually got on disability and had Medicare. I had years of every treatment you can think of, tons of hospitalizations, every therapy, pretty much every medication that was available at that time. And I was not getting better. And I believe the main reason I wasn't getting better is because I didn't have hope that I was going to get better. Thankfully, I got into a peer support program that was in the community, paid for by block grant dollars, and my peer specialist was certified, and he was the first person I ever met that had a significant diagnosis, but he had the things in his life that I was told were not possible for me. And it was through that relationship that I was able to have the hope and the empowerment I needed to reclaim my life. And so when I say that peer support saved my life, it literally saved my life because I was consistently suicidal. And it was really like my full-time job is having those thoughts and sometimes taking action on those. And so I've committed my career and my work to making sure that people have access to the peer support that I have. Now, it's challenging. I've been now a certified peer for 14 years and shared some of the different settings that I've worked in. And one of the biggest challenges is really just protecting what is peer support. So as we go into new healthcare settings, often peer support can be shifted and shaped into sort of what that agency might need at the time or what the certain sort of regulations or pay or things related to it go. So some of the biggest challenges facing our workforce are pay. Most peer specialists aren't actually making a living wage. And so somebody like myself who came off of disability, you actually want to have, more income and a better life. And then there is also a lack of career ladders. So under a lot of payer systems, or especially Medicaid, because it requires it, mostly peers are not supervised by peers, which means that if you want to advance and stay in the field of peer support, there's often not opportunities for you. And then there's a lot of issues around role confusion. So especially going into new settings, sometimes agencies don't understand the role when they're hiring peers, often coworkers, sometimes even supervisors don't understand the role. And we've seen that as a major reason why peers have burnout and end up leaving the profession. So the one thing that I would sort of ask is to invite us at the table. This is great for all of you who have attended today, but there's a lot of spaces where peer support and other allied professionals are not there. And there's decisions being made. And it's really important to include our voices. So I really appreciate this opportunity today.
Thank you, Dana. Wonderful job. I gather hope. I gather, Lauren, you didn't talk about your social work experience, but how clinicians and peers can work together. I gathered how important it is for other payers to come to the table. I also appreciate Vesper, you starting to touch on respite and the value of having a really protected, authentic service that Dana described really well. So thank you so much. I'd love to ask a couple of questions of you all that you have thankfully gotten a few days in advance, so had some time to think about. I'll start with Tiara. Tiara, would you be able to share with us how youth peer support as delivered by Warm Lines and in schools or in school-based programs are growing in popularity, similar to what you shared about what you heard on the tour of New York with the governor, and also just share the importance of research and what's needed in that space.
Okay, absolutely. So we already talked about the tour, and I'm trying to use my 4 minutes wisely. So when it comes to, let's say, the benefit of peer-to-peer support in schools, the first person that a young person is going to tell they are having a bad day is their friend. They're not going to the teacher. They're not going to the counselor. And what becomes helpful is when you have youth peer advocates who are trained, they then know who to direct their friend to. Because all too often, kids are giving kids the wrong advice, right? Because they're all just trying to navigate life or something they learned on YouTube. Like, let's try this because I saw it on TikTok. And it's funny, but it's real, right? And early intervention That's what that is, right? So having peers in schools means there's early intervention and having trained young people who know where to send their friends when they are struggling. It's also important for community building. The opposite of addiction is connection. And when you don't feel connected, right, you feel like you have to go outside in other places as opposed to inside your community to get help and to get support. School should be a hub and a place where youth can engage with their peers. They can engage with mentors. They can engage with even community-based organizations. I worked at Elmcor Youth and Adult Activities in Queens, and they were one of the first and only youth recovery clubhouses as a response to the opioid epidemic. And going into schools and pushing in schools to talk about prevention as it related to drug use was interesting, but then it was also a lot of stigma. So the other thing that youth peers bring to the table is reducing stigma. So when we talk about, you always have that parent that's like, my 15-year-old is not doing drugs. They didn't grow up in my house like that. And then, unfortunately, that 15-year-old is learning things in school and getting connected to people on the outside. So school is a great place, and it's where youth spend most of their time every day, and also outside resources. There are programs. When I was working at Elmcor, we made different MOUs with other schools to say, hey, how about we come in and do a 5-week curriculum with the young people, right? And they can get a certificate afterwards. Families Together has a junior youth peer advocate certification for youth who are younger than the age of 18, who can also learn skills around engaging their peers and also engaging themselves in self-care. Because it's a lot when you're 16 and your friend is coming to you saying they want to run away, right? It's a lot. So how are we prepping youth to have resilience? And when it comes to accessing supports. On the tour, youth said it would take about 3 to 5 months for them to see a counselor, and they would be put on a wait list because the teacher and counselor-student ratios are not equitable. And it's challenging when you're in school having an anxiety attack and Regents exams are coming up and you can't get help. So when you have peers in schools, peers do not replace clinicians. However, they do add extra support. They add someone you can go to while you are on that wait list. They add someone that you can go to, or even just a basketball game and do some respite, right? And do some recreational activities just to get something off your chest and off your mind, right? So those are 3 things that peers can do. And when it comes to funding, I think about the importance beginning to fund research on youth peer support as an effective intervention. So I want to talk about the historical disparities. So historical disparities and biases in research funding have often favored academic and medical institutions over grassroots and community-based organizations. And then this also creates a cycle where organizations lack past funding, struggle to build the evidence base needed for the future support. Research allows for the examination of the effectiveness of youth peer support across all groups, right? All diverse demographics. So whether that's ethnicity, whether that's socioeconomic status and cultural background, it's important that interventions are specific to the needs of that particular population, right? So that's what I'm talking about when we talk about equity. And then there's also a perceived lack of credibility when it comes to peer support. So peer-led and community-driven organizations, we face skepticism, we face scrutiny regarding our ability to produce credible and rigorous research. And most funding entities, like I said earlier, prioritize established institutions, assuming they have higher scientific rigor or even more trustworthiness in their findings. And then we have quality improvement. So research is used to identify areas of improvement within the program. And this ongoing evaluation allows for adjustments to be made to enhance the intervention's quality, its relevance, and its efficacy and efficiency. So, and then I want to talk about just having, as Dana talked about, a seat at the table. So lack of representation in decision-making. So when it comes to beginning to fund research on youth peer support, decision-making bodies within funding agencies lack diversity and representation from the communities that serve these from the communities that these organizations serve. And the lack of representation can lead to a disconnect in understanding community-driven research, unique needs, and their value. And as we say, nothing about us without us. We cannot go into communities and give them apples when they're asking for oranges. So that's why I think funding this research is important.
Thank you. Lauren, thank you so much for being here representing Blue Cross Blue Shield Minnesota, a statewide commercial payer of health services. Can you talk a little bit about what recently happened that might have helped lead to the new decision to universally cover peer support? Talk about your organization's behavioral health strategy and describe what you think is coming in the future in terms of your work.
Yeah, absolutely. Thank you. You know, at the same time that the president's national mental health strategy was being formed, Blue Cross Blue Shield of Minnesota was doing the same with our behavioral health strategy, knowing that the landscape for payers had changed after COVID. We were looking for ways to improve access to care for both our local members and national members as well. And we knew a couple of things. We knew we would need to expand our network of providers, and that includes both clinical and non-clinical. So when we're speaking clinical, typically you're looking at therapists, psychiatrists, psych, nurse practitioners. When we're saying non-clinical, we're talking peer specialists, community health workers in some settings, psych rehab workers, recovery organizers as well. And with this, we knew that if we could have all of these individuals at the table, we would have a continuum of care that really provided for our membership. When you're creating a behavioral health strategy, what's really important in that work is to start getting feedback from your members, right? We have a team of clinicians. We have a child psychiatrist. All of us have our backgrounds in mental health. We all have our masters. And yet, as you said, right, nothing for people without them at the table. So with that in mind, we had a member survey go out. And what really struck our team is the feedback that we received about non-clinical care, that often it's looked at as a pathway for clinical care, but that our BIPOC members, so individuals who make up Black, Indigenous, people of color, were saying, we want mental health treatment, we just don't want it how you want us to take it. We want non-clinical care just for non-clinical care's sake. That was an eye-opener for all of us to be able to hear that, and that was the ultimate push that had us move forward with the benefit option for not only Medicaid, which we already approved, but all commercial lines of business as well as Medicare Advantage. At the same time, when the president's national mental health strategy rolled out, we saw a couple of things that had been blocking us from getting the final approvals for this benefit. So to have a benefit go across the line, you need to have providers, right? So as of day one, when you have a benefit, people have to be able to access that care. So the lack of peers locally and nationally were stopping us from approval. The other piece of that is there were no national standards for peers, and we wanted to ensure that there was safe and standardized care. Those are two things that were outlined, and it is our understanding that more information will be coming about that. However, it really ensured that Blue Cross Blue Shield of Minnesota was able to get coverage for everyone and at $0. With that in mind, with our behavioral health strategy, there were a few things that peers checked the boxes on. A connection to clinical care when appropriate and when wanted, increased recovery outcomes, reduced stigma, help in rural areas, virtual care, support for youth, improved navigation, and increased care follow-up across the spectrum of care. While it took us 2 years to get this,
Sure.
While it took us 2 years to get this benefit across the line, we're proud to say that now all of our members have a level of care that they wouldn't have before. For a payer to approve a new benefit such as this and roll out all of the supports that are necessary and build the network of providers, sign hundreds of contracts across commercial and Medicare Advantage, sign amendments, meet with the state, our advocacy groups, and everything else that we've gone through to make sure that this is ready, we can say that this would be a challenging road for other payers to walk. We'll all have to come to the table to ensure that this is an option for others. Minnesota already had over 120 peer providers for Medicaid. That's not the case in many of the states across this nation. And knowing that we were in a much more comfortable spot to be able to approve this. Another thing to know is that we found that 9 months after utilizing a peer, there was ROI. It was a total cost savings. So for those who are concerned about cost, this is an affordable option for both our members, it being $0, and for payers. Thank you.
Thanks so much, Lauren. And I think you brought up a good point about the importance of helping people connect virtually online in this new space that we're in, and how peer support specialists can do that, especially with older communities who may not be as comfortable with technology. Vesper, love to ask you a question. Kiva Centers is providing peer-to-peer support annually through a respite model that allows individuals a safe alternative to hospitalization or even incarceration in times of distress. Can you discuss a little bit more about peer respite models, how they're funded, and how they're different from other ways of delivering peer support?
Absolutely. So, I mean, first starting in our state, Massachusetts, I'm giving big kudos to the Massachusetts Department of Mental Health for really supporting the innovation of respite models to include peer-run respite and to operate with the values and the ideas of peer support. Supporting peer-run organizations and operating those models, it's absolutely critical. Currently, our peer-run respite is funded through federal funding given to the Executive Office of Health and Human Services and then managed by the Department of Mental Health. And then those dollars support our peer-run respites in operating mobile peer-run respite services and on-site peer-run respite services in a home-like environment. Staffed completely by peer supporters, 24 hours a day, 7 days a week for those experiencing emotional distress. People can recommend themselves, and they can also recommend themselves in partnership with a provider if they so choose. Peer-run respites are voluntary and very, very important for a lot of folks in the community. In terms of how peer-run respites are funded throughout the country, there's a few different answers to that. It depends on what state you're in. Some people have preferred local resources, such as city or town funding versus state funding because of certain restrictions that may be in their state. Some folks have implemented funding through the Medicaid process and billing, but there have been barriers along the way in terms of billing for private payers. I think one such is usually the clinical supervision piece that is required, especially when a peer-run organization is all of the supervisors are peer supporters. We've been able to work through this process through clinical consultation and support to work through that existing infrastructure and system. We have also been training these clinicians in peer support approaches, how our process, our model operates, and what it should look like. I think it's important for individuals who come in that if they want those resources, that it is available upon request. Again, this is a voluntary model, so that is extremely important. I think another piece too is sometimes folks cross disability require different resources, maybe a visiting nurse, maybe additional needs in terms of medication or supports in the space. We've installed things such as like bed shakers for someone who's like deaf and hard of hearing if they need something to help them wake up. If they're looking for certain configuration of the space, that the recommendation process includes that level of accessibility, and that when we interview the individual and we discuss it, that those accommodations are met. I think that's another key piece of the process. Someone fills out a recommendation form, and then between 24 to 48 hours, we reach back out to them. We see if this is a good resource for them. And then they usually stay with us for 5 to 7 days, sometimes 14. We've had people stay with us for like a maximum of 30 days. That is usually the time frame. Peer-run respites can be a great alternative and a great additional support too. I think something that is so rewarding and so important about peer-run respites particularly is for students or people who are working full-time to not have a significant life interruption by going inpatient or having to have a lot of these resources and needs met. Not having their medication adjusted. People self-manage medications when they come into these spaces. I think being able to go to work, be able to continue to go to school if you so choose, and having a place of rest and self-reflection that is staffed by people with life experience is invaluable in the way of we get better health outcomes when the social outcomes of someone's life are contextualized and understood by the people staffing that facility. So I think when we talk about peer-run respites, those are the main valuable components for what we understand. Thank you.
Thank you so much, Vesper. I know that most recently, Congress has expanded Medicare coverage of mobile crisis interventions, and that those are separate and different from peer respite. But you have described here that there's a mobile peer respite model, and what is that?
Absolutely. So I would say this is unique to our state because we have a blended capacity respite, which has the on-site supports as well as the mobile peer-run respite supports. And it's a mobile crisis model where we are going to people, we're meeting them in a mutually decided location, whether that's a coffee shop, a library, or their home, and we're supporting them for 1 hour, 2 hours, absolute maximum of 4 hours, multiple times a week. This is great, particularly if your peer-run respites are full and cannot serve the need in the community because there's so much need that you can go and meet people where they are in the community in that moment and support them. I think what this support looks like is usually it can look like a variety of different things. Sometimes someone can be in crisis when they're trying to pack the boxes to their home that they have to move out of. So sometimes we're packing boxes together while we are supporting and talking about what it was like to be evicted from another home in the past. Sometimes a person is houseless and in the community and in need of resources and just needs a good starting point conversation, someone who understands them and won't judge them for being houseless. I think that's an important piece as well. And we try to match usually our team members with people who have similar life experiences. So when it's related to someone who's struggling with their substance use recovery, that someone on our team with that life experience is going to go see them. When it's someone who is houseless, we have someone on our team who can have that experience. Sometimes someone who is cross-trained as a housing specialist for a good starting point. So we try to match the need as much as possible.
Thank you so much for taking that curveball question. Dana, thank you for rounding us out. If you could talk a little bit about some of the clinical confusion that you described earlier in understanding what a peer does in a clinical setting and how they might work with other health providers, and then discuss how you've worked in the last couple of years to educate CMS about how to make it a little bit easier to be billing for peer services.
So we were very excited in the proposed rule for the 2024 physician fee schedule to see that peer support specialists got a lot of attention. So there was a set of services that CMS had defined. Unfortunately, many of those services were outside of the scope and the role of peer support specialists, and some of the language just in and of itself would have caused more role confusion within settings. Thankfully, a lot of the peer workforce community spoke out, Mental Health America, National Association of Peer Supporters, and so many more, and gave CMS some pretty solid arguments to make some adjustments. And so we're really excited to say that there is now going to be, starting January 1st, a specific code for peer support, and the list of services are completely aligned. One example of sort of some confusion is it initially listed the word assessment. And what we've seen is that a lot of assessments don't need to be done by a clinician. And so in some settings, the peer specialists have become the assessment people because it allows clinicians to work at the top of their license. And so an example of that is in the new language, the word interview is used. So we're trying to set the tone that peers have a specific role within settings. They don't just do whatever needs to be done. But there are some challenges still with Medicare. One of the challenges will be that peers will have to be billed under general supervision, and which means that would be a physician, psychiatrist, clinical psychologist, nurse practitioner, and those professionals likely have the least experience of working with peer specialists because traditionally it's a licensed clinician that has those roles under Medicaid. And then there's also currently not a provision for peer support through telehealth, and the whole mobile crisis piece still needs to be figured out. But we're very hopeful to see that specific code. There's also some challenges still that exist within the guidance for CMS for Medicaid. The existing guidance is 16 years old, and so obviously the peer workforce capacity has changed, healthcare has changed in 16 years, and some of the challenges within that guidance can also bleed over into Medicare. And if I could,
Is there legislation that you'd like to discuss around this?
I feel like, Caren, you can say it.
Dana, it's all yours. It's your bill.
Oh, I was going to talk about the Peer Support Act.
Yes.
Oh,
Yeah.
we're on to that one. Okay. So very excited about the Peer Support Act. Senator Kane introduced that this summer. It does a couple things. One, it defines peer support very clearly. So a lot of times peer support gets kind of described however it gets described, and this does a great job of defining the lived experience for both adult peer support and family peer support. And then it ask for a federal report on background screening. So many peer specialists come in with some criminal justice involvement, and that lived experience is the very lived experience that provides value in the work that they do and allows them to connect with people with that similar lived experience. But it can often be a barrier to employment or to sustaining that employment. And so this federal report would give kind of a survey of what states have now in terms of disqualifying offenses or barrier crimes, and then also report on any innovations such as background screening exemptions and other things that states have done to address this. And then the bill would also codify the Office of Recovery, SAMHSA's Office of Recovery. And I think we would agree on this panel that SAMHSA's Office of Recovery, which was recently created, has been a huge help to the peer support workforce. The national standards of certification are a product of the Office of Recovery, but it's not codified. And so we want to make sure that it stays around to continue to support us and be a beacon of information and light for us. And then lastly, the bill would require the Office of Management and Budget to create a specific, I talk about this all the time.
SOC.
Yeah, thank you. Standard occupational classification for peer support professionals through the Department of Labor. So right now there isn't a specific code for peer specialists. Our data is being rolled under community health workers, and yet the apprenticeships are actually being under a separate code. And so because we do not have that specific code, we basically have very little data. And because we don't have data, it's very difficult to do strategic planning and really identify where the workforce needs are, to understand who our workforce is and how we can grow, especially diversity within the workforce. So we are really hopeful that we can get that standard occupational classification specific to peer specialists, and because that is critically important as we continue to expand. That code is used across federal agencies, Department of Education, Department of Corrections, and so it's really critical to our success.
Thank you so much. And that's a bipartisan bill. So Senator Kane introduced it with Senator Braun from Indiana. If you know either of those senators, please let them know you appreciate their activity and leadership in this space.
Yes.
I'd like to open it up. We're at just 5 minutes left and wanted to allow questions from the audience if there are folks. And I think there's one in particular from Alexia here, who is visiting us from the Delaware Lieutenant Governor's office. Alexia, please.
Certainly. Thank you so much, Caren, and thank you to the panelists for the wonderful presentation. I'm the director of the Behavioral Health Consortium in the Office of Delaware Lieutenant Governor Bethany Hall-Long. I also serve as the elected chair for the National Association of State Mental Health Program Directors Division of Recovery Support Services. So really want to amplify the voices of my colleagues in states throughout the country in saying how much the initiatives that you're highlighting and these advancements align with our interests and how much we value the work of the SAMHSA Office of Recovery as a convener in these matters. So thank you so much for hosting today, and thank you for the wonderful testimonials.
Thank you. I was not aware of your position with NASHBID, so that's really helpful to know, and we continue to look forward to working together with you all to advance peers. Are there other questions from the audience? Yes.
Hi, I'm Malcolm with Congressman Jayapal's office. I was wondering, you touched very briefly on this, on incarceration and peer support services, and I was just curious if you could speak a little bit to federal barriers to that kind of work within justice settings, within criminal justice settings.
I do think a lot of it is state level, but we actually have a peer here, Kim Comer from Florida, who's visiting from Palm Beach County and can discuss more as well. But I think a lot of the barriers end up being local to states. For instance, Georgia has passed a waiver or appeal process if someone is denied employment because of their background check and they're a peer specialist. There is a process they can go through to try to get through and end up working back in that setting. There are certainly some other states that have really a penal approach and are not so friendly, and I think more advocacy really is needed to be done, but having the study done at the national level through the Kane-Braun bill will help to draw some attention and allow us to figure out which states are doing it right. Thank you so much for joining us. Andy?
Andy Kessler, and I represent a lot of interest in recovery and treatment, including the ICRC. And my question for anyone who wants to take it on is, this is still a young profession. And I see one of our biggest challenges as standards across the board. We can't grow as a profession, which I want us to do, until the payers and us agree that what is a peer, And I know it's tough to say because it's a really kind of fluid thing. So what are your ideas for making standards that we can all agree on so we can grow as a profession and be taken more seriously? So a peer in California is a peer in Delaware, like other professions, because I see that as one of our biggest challenges because the standards are so disparate right now. So any ideas you have, I'd love to hear.
I'd be happy to share a little bit. Happy to share a little bit. I know, after the president rolled out national standards, currently many of the states are meeting with the legislature right now. So in the state of Minnesota, we have the Department of Human Services, who my understanding is meeting with the legislature to be able to roll that exact thing out. We know that it's challenging to add different types of peers, even though I think all of us can agree it's vital to have that support. And yet when you don't have that standardization in training programs, certificates that apply across in a workforce, grants to be able to support individuals wanting to get into this, ongoing training, and the list goes on. It can be incredibly challenging. I do think there's an opportunity for peers and others to connect with their local Department of Human Services based on whichever state you're in to be a part of that process. Because I think, like Dana was mentioning, wonderful what CMS has rolled out, and yet when you're not directly in the field, it can be challenging to know kind of the ins and outs, right? As a social worker, the same thing had happened in the profession that I'm in. And so it was something we just had to get more closely aligned on. But the great news is we're moving towards it, right? And so I think this last year has really shown us that we're all headed in the right direction and having these conversations. Thank you.
I also think we can include kind of like core values of standardization that we see through an APS and SAMHSA. I know that those recommendations are, again, broad, but when you look at rural mental health versus rural behavior or urban mental health, for example, different approaches are needed. People are coming from different communities. They're facing different things. So there is value to the localized approach. I do think that there can be general standards that to a certain degree are encompassing of different peer support and lived experience professionals, while simultaneously maintaining the value of those localized supports. I think in order for us to get there, though, there will need to be a series of listening sessions. There will need to be a lot of broad discussions. There will need to be a lot of conversations about the serious barriers and the serious opportunities that can emerge from this as well. Because again, we're talking about better health outcomes when someone has that lived experience context. When we talk about what it means to be trauma-informed and trauma-informed being a best practice, we're talking about trying to be as knowledgeable about what can be potentially traumatizing or is traumatizing to an individual as possible. Or SAMHSA's definition of trauma, which is something that can be both directly or indirectly felt. How are our communities indirectly and directly experiencing trauma, and how can the specific context of self-determination, life experience, really illustrate the narrative of what is impacting that community specifically? What professionals need to be trained in what approach in that area, and what does that certification look like every year?
Thank you. I know we're just a little over time, so want to allow folks, time to step out if they want. But we're happy to have the conversation as long as you're here.
Yeah, great. I'm a patient advocate, and I like to call myself a lived experience expert. I refer to people with lived experience as those with lived expertise, as opposed to lived experience, because I think it's important that in the workforce we are seen as equals, as consultants, especially when you're working with for-profit organizations where they will not want to compensate people with lived experience in the same way that they compensate other people. And so, Dana, I was really interested that you brought up the point about a living wage. So, all of these the legislation is great. It's wonderful that in Minnesota the payer is making movement there. But if you can't recruit people to this very important career path, and if people have to have more than one job to do this, number one, how can they be effective? And number two, how are you going to recruit people? There's no pathway for people with lived expertise, for instance, to get an MPH that's paid for. I'm currently getting an MPH, and I did the research. There is not one program in this country that gives opportunity for people with lived expertise an opportunity to get an MPH. So I'm just interested in hearing from whomever wants to answer your thoughts on that.
I'm happy to start, and then it looks like a few people biting at the bit here. And we absolutely would agree from Blue Cross that it's really vital that for this workforce that they are paid a living wage. And with that, I mean, we're undergoing a very extensive process over this next year to engage many of our peer providers to hear exactly that. What are the impacts of now having this across all lines of business? We know peers travel into the community. It's one of the only mental health and recovery services that you'll find that will go to someone's home, meet in a coffee shop, meet them at primary care, wherever that individual is. So, we know there's increased cost in mileage, obviously hourly wage or salary, but what else is coming up? And in that, to then be able to determine what would be a fair and equitable reimbursement rate that we're paying. I think the other piece to that is seeing, at a federal level with CMS, what are the rates? Could we have those go up? We've seen this with community health workers and doulas locally in the state of Minnesota, that as those rates have continued to increase, it helps payers to be able to just ensure that there's continuity across lines of business. That's something we'd like to see with peers as well. Thank you.
And if I can add, Georgetown University and a couple other universities are working on transferable credits. So your certification as a peer specialist, your certification as a peer recovery coach, or whatever life experience profession you're working in can be transferable and encouraging in that way. That's a first step, though. There's so much more that needs to be done in that area, but I think that that's a part of it. There is an encouraging piece as well with continuing education, as well as continuing pathways in terms of people working at different levels at peer-run organizations, continuing to work in lived experience roles. But again, those opportunities have to be available and they have to be appealing. Right. We at Kiva Centers, we pay people starting salary $22 an hour, but that can come out of admin. That comes out of other budget lines. It doesn't come out of, it is not built into the grant or the contract to pay the peer supporter that much.
Yeah, so there has to be advocacy at the state level, and I think transparency is helpful. So most people don't know actually what rates are across different states. And so I believe SAMHSA is going to be putting out a report soon that details that. But for example, $25 a unit is kind of where the high point where it'd be helpful to be at, because many are 15, 10, even lower. And then additionally, really focusing on sustaining the workforce. There's tons of talks about like getting new people in, but really making sure that we're able to keep the peers that we have, because SAMHSA actually put out a report recently that 1 million more peer specialists are needed to meet the growing demand for mental health and substance use. And if we're losing peers, which we are right now, that's not possible.
We're also I'm gonna wrap up and conclude, but wanted to just mention that a part of the reason we've been working so hard with Senators Cortez Masto, Senator and Congressman Smith, who is here today, to get coverage in Medicare is because that would set a national rate for peer support, and we know Medicare rates are typically higher than Medicaid, and we hope that that would encourage states to increase payment rates. Thank you all so much for coming, staying. Please enjoy some food if you haven't been able to yet. And we have a leave behind that you'll receive on the way out. We really appreciate your attention. And if you have any follow-up questions, don't hesitate to get in touch. Thank you.